Okay, so let me get started. Eric, first of all, I want to thank you. It's good to see you again.
Good to see you.
Can you just, for the sake of the folks that aren't familiar with you, can you give us a little background history on your story? I know you're a physician out in Pennsylvania, and well, I'll let you tell that. Go ahead and give us a little background if you don't mind.
Yeah, sure thing. Thanks, Sean. Yeah, I'm Eric Sodicoff. I am a internal medicine slash obesity slash part-time hospitalist physician in suburban Philadelphia. Went to Temple undergrad, University of Pittsburgh for residency, and then I've been mostly in private practice out in the western suburbs of Philadelphia since that time. So that's kind of basically what I've been doing. Kind of segued into more lifestyle stuff when I made the switch from kind of full-time hospitalist to primary care, and I didn't know how to answer the question, how do I lose weight, doc? And when I went looking for the answers, it didn't really make sense based on kind of some of my background and what I've been seeing in the literature. And that's when I kind of went digging into doing some extracurricular reading, and I came up with answers which didn't jive with what we were being told.
Yeah, and I think a lot of people discount clinical experience. I mean, you see what you're supposed to do, and then you repeatedly see maybe it doesn't work that well, or only works in, certain settings, maybe in a specific lab setting when all the variables are controlled. And then when you put humans out in the wild, so to speak, in their own free living environment, there's a very different set of things that tend to happen. And I think that's something that a lot of the researchers tend to discount, that we actually live out. We don't live in metabolic wards, and we live in, society that has a lot of other influences on us. You are obviously in the low carb camp. I think you are, if I'm not mistaken, you are even so bold as to be somewhat carnivore friendly.
Oh yeah.
Can you tell us where you made the decision, and probably similar to myself, where I kind of started, on the low carb train, and it kind of snowballed from there. But how did you start to shift from whatever you were doing before? My assumption was kind of a low fat, calories in, calories out approach to maybe a low carb, and I'm not discounting calories, but I mean maybe a low carb paradigm, I suppose.
Yeah, well, I was kind of primed to be skeptical about kind of the regular teachings, because in college I was like, I found myself in a biology lab where we were actually studying hibernating animals from Colorado. And we kind of learned about these things called LDL receptors and HSL receptors and things which control fat. And I did that, and then I went to medical school, and the dietitians were like, no, it's just calories in, calories out. And I just kind of shrugged my shoulders, because I figured that they were the experts on human nutrition, and I just was, did my thing and let them do their thing. And so that's where my questioning started coming from. And then when I got to around to reading people like Gary Taubes, and I saw that he was quoting some people that I knew, I was like, oh well, this must be where all the smart people are going. And hugely, it was like there's a guy, his name Will Yancey, who actually helped who later on went on to revise the American Diabetes Guidelines. So he was he was my senior resident when I was an intern. The guy, in the middle of the night would help me not kill people on my first year internship. And he went on to be one of our chiefs, and then he went on to become a professor at Duke, working with Eric Westman. And he did these awesome studies where he was able to he was putting people on the low carb diet and the Atkins diet, and he was able to get these people, down, their doses of blood pressure meds down, their insulin down, their all their diabetes meds down. And I was like, wow, this is great. And I know Will, and he's a really super smart guy, and everyone really respected him. And I'm like, wow, this is where smart people are going, and that's what I figured that I would be doing this. And he's like, and he basically proved that if you do this with real patients, these were vets, by the way, you don't get more real than vets. And these guys were all thriving on the low carb diet, and that was like, that's it, I'm done. Let's just go ahead and start doing this for my patients.
So when you made that shift, I guess were you still a full-time hospitalist at that point, or had you already kind of jumped over into the more primary care?
Yeah, I was started having more office hours. It wasn't like it was one jump was the other. It's just kind of like I started opening up more office hours, and I just wanted to get better at that. And so, but yeah, in the hospital, none of that really, nothing about nutrition really matters, and it's all like procedures and stents and meds and life saving and that sort of thing.
Yeah, and I'm sure you share the frustration, particularly when you get a hospitalized patient, you often get a sliding scale and a sliding scale of carbohydrates to go with it. It's got
right.
And so the hospital, I mean, obviously we're talking about chronic disease, but when people are acutely ill, which is, why they're in the hospital, but usually they're acutely ill because of their chronic disease. We just I don't think we do much to help them with regard to nutrition.
No, you walk in on rounds to see your patient, your diabetic patient, who you have the sliding scale on, and you see that they have an English muffin or a banana sitting on their tray, and that was like, why do you need that? Well, because the dietitian said I need it on there. If for whatever reason a patient decides he does not want to eat an English muffin that day, he's getting one anyway, just to make because otherwise you're breaking they're breaking the rules down in the kitchen.
Yeah, you might not get a high enough blood sugar to need insulin if you do that. So
yeah.
I know, and I've seen you, obviously on social media posting some of those things about that, and I know you talked about that before.
Right.
Do you think, was there at some level of frustration that you had as a physician? And I know many physicians are sort of a little frustrated with the standard medical practice that we kind of grew up on. And did you develop some level of frustration at some point?
Yeah, there's a certain level of frustration where, it just doesn't feel good. Somebody comes into you with their diabetes. It's not quite at goal. You sit there, you tinker with their meds, you bump up this, that, or the other med. They come back maybe in a couple months, their A1C is a little bit lower and everyone's happy. But it just didn't feel like it's like, and you're like, really, that's it? I just, just sit there, I just tinker with the meds there. They still look as unhealthy as they did before. They're equally fat or fatter. Their abdominal obesity is exactly the same. Waist circumference is exactly the same. Body mass index is, the same. But, they're hitting their goals because their blood sugar is now lower or blood pressure is now lower. But it didn't seem like other than masking symptoms, so it never really felt really, really well. And my level of satisfaction with what I'm doing really jumped up when I kind of, changed the whole paradigm I was using from using, the meds as my first line intervention to, hey, why don't you try this diet? And the first time you see it, when you see a patient, do better that way, is just like eye-opening. You're like, holy crap. Because it's never just one thing that gets better. It's like everything gets better. It's like, this week, your A1C is like 4 points lower than it was. And, by the way, you're feeling lightheaded now. Oh, that's because we have you on all these meds. These meds were designed for a person who was, 50 pounds heavier than you. So we can take those off too. So it's kind of really eye-opening and amazing. Once you do it once, you want to do it for everybody.
Yeah, the points that you even talk about, abdominal circumference and, central obesity, I don't even think most physicians even give much credence to that. It's kind of, like you said, it's an afterthought, or even, it's not even a thought in many cases. I know in my specialty, other than just frustrating me because, if I have to operate on an obese patient, it's going to be more work in the operating room. But beyond that, it was like, that wasn't really something I, spent a lot of time dwelling upon. But
no, yeah.
it's when you talk about, yeah, you can get the A1C maybe a little bit lower, you can get the blood pressure a little bit lower, and obviously you're putting on all these medications to do it. And,
Right.
like you said, when you look at the ADA goals for a diabetic, I mean, they're pretty abysmal. I mean, they're looking at, just get the A1C below 7, and that's all we care about when we know that that is not anywhere near.
Just get it below 7
Yeah.
here. Don't go any lower than that, or else you might have those dangerous hypos. Yeah.
Yeah, I mean, and that's something that is, obviously there's some drugs that are more likely, particularly sulfonylureas and obviously insulin, which you have this predisposition for hypoglycemia, particularly when you go low carb. But I mean, and not to diminish the importance of hypoglycemia, because, obviously people can get very sick and some people even die from hypoglycemia. But,
Right.
it's how do we get past that sort of mindset that, oh my gosh, we can't have anybody with a blood sugar of 70? I mean, it's just, I mean, that like for a diabetic, oh no, and you know perfectly well, there's people sitting in the 50s and 60s, and KL brought them down even to the 20s in
Yeah.
ketosis, and they were fine. And so,
They're fine.
what do we? Go ahead, Eric.
Yeah, no, as long as you got a backup plan like ketones or something like that, then you're good. I mean, that's how Cahill did it, and then I think Dom DiAgostino did some on himself as well. Yeah, how do you get beyond that? I think whatever the guidelines have to reflect that reflect that there are different ways to achieve these goals, and lifestyle. Even though they always say, "Oh, lifestyle first," they don't really mean it. They got it's written in small, tiny print on these guidelines, and it's like lucky if it gets 1 or 2 sentences at the top of any guideline. Lifestyle, and then they quickly pass that, and then we just discuss meds. You'll have an entire journal review about which meds you should be using for this, that, and the other thing, and a stepwise approach to applying medications. And so, but we have to maybe in the guidelines recognize, well, if you're doing a lifestyle approach with less meds, then it is okay to shoot for these lower targets. If you have a patient who is following this diet, that it is okay to actually shoot for below 7. It is not dangerous because you are not on these blunt instruments with like injecting insulin, or a blunt instrument like a blood pressure pill. Yeah.
Yeah, I mean, and we have many type 1s and type 2 diabetics in this community, and we routinely see 4s and 5s, hemoglobin A1Cs of 4s and 5 without any issues with hypoglycemia. We've got
beautiful
type 1 diabetics that are on the least insulin they've ever used in their life. I mean, minimal basal dosing. And so it's just amazing the difference in that. And that is a frustration I share, because I still do my CME, and anytime you look at any disease, it's like, yes, sometimes there's a little bit of lip service toward lifestyle. And then 95% of it is dictated on which drug to use and this and that, and I guess because there's so many darn complications and different indications and nuances to using the drugs, that they have to spend that time. But I mean, as you know, often these CME conferences, these CME lectures are sponsored by Pfizer or AstraZeneca. I mean, you see it, and it's just obviously clear. I mean, I think Medscape, which you probably get bombed with their stuff in your email, is, I think, funded 75 to 80% all by pharmaceutical companies. And
exactly. So, hey, learn how are you managing your patient with type 2 diabetes here? Come to watch this educational program, get a CME. But it's all it's all going to steer you to using XYZ drug.
What many physicians, and certainly many patients, many patients don't even know. I mean, they just do what their doctor is told because they trust their doctor. But many physicians are concerned with, I mean, they talk about burnout, and that has to do with, just working all the time, dealing with insurance companies, dealing with the electronic medical record, which is provided as a frustration for many physicians. Do you see some alternative options out there for physicians, or many more physicians starting to take up the, I know some people are going into DPC, direct primary care. Some people are doing concierge. They're kind of unplugging from the system.
Yeah.
Do you see a greater trend of people doing that, or do you think we're going
Well,
to see?
I certainly know people who are doing. Obviously, there's the Tro and the Brian Lancases of the world who are going in that direction. I'm still soldiering on under the traditional, insurance model where the vast bulk of patients are. So, and that's going to be required because a lot of people don't have resources to pay anything at really much out of pocket. So, these people definitely need to be serviced. It is frustrating because a lot of times, our incentives are ones which are tied to hitting marks, which now I've come to believe are just not really super valid, like A1Cs, is like simply blood sugar targets. I think probably should be trying to hit cholesterol targets as well. Whereas I think that none of that really matters, and I think we're shooting for the wrong targets most of the time.
Yeah, I don't disagree with that, Eric. I mean, I saw a frustration from a healthcare provider. I think she was a nurse practitioner. Said, she's getting letters from Medicare saying, "I'm not hitting my targets for a number of people that are taking statins for, for whatever, LDL
Yeah, you
levels
get those.
or."
Yeah, you get those. You get those emails. Well, by the way, they'll say, "Hey, there's a quality improvement opportunity in this patient." You'll get a fax. Plopped on your desk.
Are you seeing in your personal practice or people that you know where those targets are tied to income to some degree?
Not that I'm aware of that the targets are tied to income. It's just whatever if it's I don't know if these sometimes they're CMS targets or they're whatever insurance company targets.
I've seen some physicians make that claim that their bonuses are dependent upon
Oh yeah, some bonus, yeah. So there's things like these accountable care organizations where basically they're basically chasing after the carrot, which the government is putting out. And if you're somehow if you don't really subscribe to that, then it's not, then you're maybe missing out on an opportunity there.
Yeah. So there's a, and I know these aren't huge amounts of income, but it's definitely some income.
Yeah, it's like there's something there. It's like, hey, yeah.
What do you have you are you basically are you in practice by yourself in your day job or are you in a group, and if so, are you getting any pushback for this low carb approach?
No, actually not. Believe it or not, actually, I have a good support. I mean, I'm really the only kind of guy who's really pushing low carb with earnest. I mean, I work in a very large multi-specialty, multi-office group, multi-hospital group, kind of a complex but organization. But we're independent of any sort of hospital system. And so I don't really get pushback. I just have some people, queer, it's like, oh, that's kind of weird that thing that Eric does. I'm the keto guy. So, but I don't get pushback. In fact, other people I do hear actually a lot when I down the hall, I'll hear people kind of, as they're dictating, they'll say, oh, recommend low carb diet. From even cardiologists and senior members of my group, I hear them talking it up too. So I think I'm kind of having an influence on the rest of the members of my group. So no, and I have like even cardiologists sending people to me, and like vascular surgeons sending referral GYN doctors sending people to me to help their patients for their various problems for me to try to get some weight off of them, so it's great, so that's in my kind of, when I'm wearing my kind of obesity medicine hat as the referral specialist. So I'm actually getting people sending him to me because of that little special expertise. And that's kind of the reason why I kind of got into it, because not just to help my patients but to help other people with like severe end stage problems. for example, like the vascular surgeons, they've got all these people with lymphedema they can't do anything about. They could sit there and they can wrap their legs all day long, or they could strip veins, but if they still have a body mass index of 40, 45, 50, they keep on coming back with their, leg ulcers, or venous stasis dermatitis, over and over and again. And it's really no hope of them ever really, getting better. Maybe temporarily that ulcer will heal, maybe not. And I've got really good uptake from vascular people who just said, listen, you got to go and get to the root cause of it, and they send them to me.
And that's interesting because, and I used to see those patients all the time, these morbidly obese people, and, you just see, and sometimes I'd end up cutting off their legs, because it's just these infections just, particularly as they got into, dry, gangrene. And, I can remember in residency one time walking by, and we took care of a lot of prisoners, and we had a guy who had dry gangrene, and it was just like literally the toe just twisted off. just like twisted off, and you just pulled it right off. It was like, here you go, your toes off. Yeah, it was just like literally he grabbed it and twisted it and came right off. Sad to say, but what kind of success are you seeing with those types of things with low carb? Because with venous stasis ulcers and these giant cellulitis issues, are you having? Because these people that get to 400 pounds, 500 pounds, they have some serious metabolic damage, and often a lot of psychological stuff that goes with that to allow them to get there. So, what kind of success are you having with those folks?
Yeah, I'm not making these people into swimsuit models, but, if we could back them away from the precipice of, amputation and just get them, back them off there, that a lot of the times those wounds will heal. Instead of that, big, beefy, red, hot, leg, they come back the next week and it's a little bit pruned. There's all that tissue tension is, the tissue tension is down there, the swelling is down, the weight is down, and I think that's a win. That's a win because now they're not, definitely going to form that ulcer up again. They're gonna, we're gonna be able to heal that up, and if they can, and maybe they'll lose 30 pounds, 40 pounds, 50 pounds, and that they'll still be morbidly obese, but at least we're going to save their leg, and we're going to save them hospitalizations.
Yeah, they're not 2 weeks away from an amputation or something like that.
No, you're pushing that down the road. Yeah.
Well, and hopefully forever for some of them that really stick with it. Let me ask you, because obviously this platform that we have, there's a lot of people in here, getting support, and we have this huge coaching platform, and we have all these support meetings. How do you do you have some help? Because it's tough. I remember as a physician when I was practicing, trying to get this message out. I had some flyers. Hey, watch this video. Go read this book. Do you have any help beyond that? Do you have some sort of ancillary people that can help you implement low carb diets? Do you have coaching teams? Do you have something that can help you to make this happen? Because I know when you're busy, it's hard to really spend the time you need to.
Well, yeah, I do. When I first started this, I was kind of all alone, and we had a dietitian that worked for our group who was definitely in the old school model, and definitely did not like what I was up to. And then that patient, that dietitian went away, and we actually kind of started consulting this group that's fortunately in my area, based out of Philadelphia. And they have dietitians. They do functional medicine. They've got all these dietitians, and they are not afraid of doing low carb keto. And I don't know about carnivore. I don't think they quite go that far, but they are definitely not cut from the old school mold. And it's been really great because I can sit there. I usually spend a heck of a lot of time doing kind of going through dietary modifications myself, and people look at me like, oh my God, I've never had a doctor do this before. But that's why I created my own website so I can extend the learning for my patients out there. But then now it's awesome because, like I said, listen, okay, I know this is a lot to lay on you in one office visit, but we have dietitians, and they even accept insurance, and so it's just really a good way. So I am not alone. I initially was, but now I actually have people who are, help me out.
That's wonderful to hear. I mean, and many don't have that sort of resource there.
Yeah, it's pretty awesome. Actually, yeah, this group, like, they helped me out. I remember I was doing some work for the Nutrition Coalition, and they supported me 100% for when I was doing that campaign for the Nutrition Coalition. And that's how I got hooked up with these guys. It's like, oh my God, you guys are awesome. I love you, and you're in my area. This is great. So we've had a great partnership ever since.
Do you have what propels many physicians, myself included, to sort of go down this diet and lifestyle route was personal experience with declining health, and just kind of figuring out, hey man, I got to fix myself first. Did you have any experience like that?
Yeah, I mean, for me personally, I was in the middle of reading, I think, Gary Tao's book. The first book I read from him was like Why We Get Fat and What to Do About It. And as I'm reading, I'm like, oh my God, this makes so much sense. And I'm going to get these carbs out of my diet. And then and I had done a 5K, and I'd messed up my hip. I thought I maybe had a labral tear or something like that. And for months, I wasn't doing anything much with exercise. But I just had cut out carbs. And then this was like in March, and then by July or June or July, when I pulled out my summer pants, my shorts, none of them fit anymore. I was just like, boom. So I had pretty bad heartburn. I was stealing any sort of proton pump inhibitor that was in our sample closet. I was popping one of them every day. I was in the hospital. I would keep a bottle of Tums tucked away in a cabinet back in the lounge, just so I can get that too. I was, gassiness and all that stuff, and all that went away as soon as I kind of kind of went on low carb. Actually, the heartburn kind of gradually went away. It was 99%. Now it's 100% gone. I thought I was going to be on it forever because I was on 15 years. You've got you're popping pills for 15 years, and you're like, oh my God, snoring. My own waistline went down. My pant size was up to 35 at one point down. Now it's down to 30. So yeah. I didn't want to be a hypocrite. I like the idea of talking about lifestyle, but I was beginning to feel like I was being looking like a hypocrite when I was talking about it. And then now I don't. So that's my personal story.
Yeah, I mean, I think it's important to practice what you preach, and to sort of be able to defend what you're doing by, at least, I know, and again, there's some pushback against this, but I know there's a lot of people that will be frustrated because they'll go in to the doctor, and the doctor will be 40, 50 pounds overweight, telling them how to eat. And you're kind of like, well, doc, maybe you should take your own advice, or maybe not take your own advice. I mean, it's kind of frustrating.
Yeah, before doing this, I mean, I would somebody would come with me with heartburn, and you're like, oh, here's PPIs. It says you're only supposed to be using this for no more than 2 months, but everybody takes it forever. Once they're on it forever. And I thought that's basically what I was. And then boom, hey, funny thing is, you can cure that reflux disease. You don't have to live with it forever. It's like amazing, because I knew that, oh, well, by the way, it's not good to be on these meds forever, but nobody knows how to come off of them. You can do all those things that they tell us to do, elevate your bed, don't eat spicy foods, stay away from caffeine, all that stuff. Okay, all right, that's fine, but it really doesn't work in the long run. Whereas if you just kind of change do a radical makeover of your diet, boom, it goes away, and it has nothing to do with those recommendations.
Yeah, just if you don't mind delving a little more, because this is a topic that a lot of people see with heartburn. I mean, why does a low carb, and I see this very frequently, in a low carb or carnivore diet, that they do report that heartburn goes away. What's going on with heartburn? Because the traditional treatment obviously is the typical Band-Aid. You have too much stomach acid. when we're supposed to have stomach acid. That's what some stomach does. And so we're just going to shut down stomach acid production with a PPI or something like that. And I mean, that just causes further digestive issues because you can't digest your food. So what is going on that causes, or I guess more importantly, why would you suspect a low carb diet improves reflux? Because obviously you're not impacting stomach acid, I would assume.
Yeah, I think, well, the stomach acid is there to kind of digest that meat. What was the name of that physician who was famous for, like, you know, throwing meat into this guy's stomach? There was a guy who had, a guy who had like a hole in his stomach from a gunshot wound.
Oh yeah,
yeah.
I can't remember. Yeah, it's like, you know, I think 1800s or something. I can't remember.
1800 anyway. Yeah. So all that acid is in there, and you know, you would say, you know, he would like fish a piece of meat on a fishing line into this guy's, a piece of silk into this guy's stomach, and he would, you know, it would be a completely digested in short order. Meat was like the most completely digestible food. Anyway, so what's going? Yeah, you know, the acid is going upstream. At the lower esophageal sphincter is like opening up and allowing the appropriately, like, the pH of 1 hydrochloric acid to wash up into the lower esophagus, or even higher. And so the question is why, what's sending those abnormal signals in you know, to the lower esophageal sphincter, so in those contractions making it wash backwards rather than propel it downstream into the duodenum. You know, I'm not exactly sure. I guess there was a talk about maybe it's something that has to do with leaky gut. I really don't know what the mechanism is.
Yeah, I mean, I've seen some people propose that, you know, when you put like particularly like fermentable foods in there, which would, you know, be carbohydrate based, they cause more distension, more stomach distension, which is just a mechanical, and it overwhelms LES's capacity to kind of hold food back in. But you know, I don't know if that's completely true or not, but that's been what I've been told. But
yeah, I guess fermentation. I guess you know, anything gaseous down. You know, yeah, that makes sense to me.
Do you see any long-term negative effects? Because if you're on a PPI for the rest of your life, I mean, what are some of the potential downsides to that?
The big thing that I noticed, and once I kind of, you know, once I read like maybe a little study about this, I was like, so this is when I was sitting in the emergency room day after day after day. I began to start taking notice about what happens, about who is coming in for pneumonia, you know, but getting admitted for pneumonia. And I would say it's an insanely high number, maybe 90% or above people coming in for pneumonia. And if you just take a peek at their med list, oh my God, there's a PPI on almost all of these cases. Like 90% of the people, you'll see, oh, there's omeprazole, oh, there's Nexium, oh, there's Prevacid. Always, it's like lurking in the background. It seems so benign, but pneumonia, I think, is one of the biggest thing. I mean, you're true. They're old. Most of these people who are getting pneumonia, getting admitted, are these older people. But you would say, wow, yeah, is this really the common link? Is this really making it happen? So I think pneumonia is a big thing.
And that would be the assumption is, you know, even though your acid level is down, you're still having reflux. You're still having particles that are coming up and being aspirated into the lungs. And that's probably a nidus for pneumonia. So, I mean, I think
that's right. The PPIs do nothing to stop that lower esophageal sphincter from opening up. So it just makes it less painful when the acid comes back in the wrong direction. That's all it's doing. It's not stopping any other physiology.
Are you finding, you know, with your kind of focus and your specialty, and, you know, when you get to do that, are you finding certain things are more effective for getting people to adhere to whatever diet you put them on, whether it's, you know, low carb, high fat, keto, or even perhaps carnivore? Are you finding some people are more receptive than others? Some methods work better than others with you know, impacting people to actually do it or try it or stick with it?
Yeah, that's the hardest thing, is, you know, trying to figure out who. I just try to pitch it to anybody who has an illness which I know would benefit from it. So I try to, sometimes the best thing I can do is just try to, is to try to point them in the right direction, make sure they don't get lost on the internet, going to sites which are kind of not reputable. Sometimes I tell them what what their future is going to look like if they don't, turn things around here. I mean, and a lot of times, one of the hardest things is, oh yeah, I 100% agree with you, doc. But then I went home and, and somebody says, oh, you can't do that. You're going to get a heart attack or like that. And then I have, I do my best to try to counteract those arguments. Yeah.
Yeah, I mean, and I think that is a big battle. And I know you said even cardiologists are supportive in your community, and those guys tend to be the very cholesterol centric, the diet heart hypothesis guys, because
right.
I mean, all they see day in and day out is cardiovascular disease, and so that's
right.
all they care about. Whereas, even if we want to make the argument that high cholesterol in 100% of the people, regardless of their metabolic health, leads to cardiovascular disease, we still are discounting all-cause mortality. And, you might say, well, I'm going to die of a heart attack, maybe more likely, but maybe I'm not going to get cancer. Maybe I'm not going to get, die of dementia or infectious disease or something like that. And so if you had, if you could wave a magic wand and say you had all the support you could possibly need, and, how would you, and you just had, say you had your typical patient that's, 100 pounds or 75 pounds overweight on multiple meds and doesn't have a supportive environment in the home, and, it's got all these doubts and concerns. What would you do to sort of convert that person, have them adhere long-term, and, hopefully, have success with this? What do you think it would take?
Well, I think it takes a lot of support from the environment. So, having a supportive, all that stuff, having a supportive spouse, having other doctors who are supportive. I mean, if I could wave a magic wand and have everybody do that, that's part of the reason why actually I'm also involved with the Low Carb Action Network, because, to get this, so we can get, the medical community on board, the dietitians on board, the government guidelines all aligned. So it's not just one person, one person. They could dismiss one crazy doctor in the office, but, and have this all these types of, non-traditional, dietary approaches, get, mainstream play. And so I'm not, I'm not just one guy sitting in an office, kind of, screaming at the world. I don't want to be a kind of a maverick. I just want my patients to get better, and this is the only way I know how to do it. So, but yeah, so that's what if I could wave a magic wand, either get rid of those stupid guidelines or change them for the better. But right now, it looks like we just get rid of them.
And I don't know if that'll happen, unfortunately. I mean, the USDA, as you're probably well aware, part of the Low Carb Network, and I know Nina's been championing on as hard as she can and doing tremendous work, but I think I'm sure she's beating her head against the wall, because, as much effort and time and, studies that have been done that show that we radically need. It's frustrating. And that's why I almost say, look, I think we can't depend upon the government. Now, it's frustrating because, kids in school, particularly those ones that are dependent upon the lunch programs that are, of low income. I mean, I just saw somebody post a picture of, it was non-fat, sugar added yogurt plus a juice box plus a sugary breakfast cereal as the kids' breakfast, because it goes so low it's bitter. These kids start their day out with that stuff. Yeah. I mean, it's like welcome to your next generation of diabetics. Yeah. And so
they should just not say anything at all. They should need to go away. If they're going to just be wrong, they just need to go away.
Yeah. I mean, certainly if they're contentious and we can't get a consensus, and I know the frustration is, 60% of Americans now are overweight, 43% are obese, 88% of us are not metabolically healthy. And so who are these guidelines written for?
Right.
I think, and I pointed out in the past, and some others have looked at Brazil, which I think their guidelines is eat whole foods, try to cook at home. I mean, I think that's basically the essence of their dietary guidelines. And we would probably fare better under something like that than this prescription of, 55, 60% of your calories from carbs, 12 servings of grain a day, I mean, I think it's just ludicrous. And when I go back, even from an evolutionary perspective, and think, how would I have ever possibly eaten to the dietary guidelines as a human being when some of these foods don't even exist on the same continent, not alone, not to say the same local area. I mean, it's just
Right.
bizarre.
Yeah, you don't have to go anywhere. I mean, I've got there are cows down the road from me. There are chickens down the road from me. What else do you need?
One of the things that, and I know, I don't know if this is something that, we're trying to do with this MeatRx platform, and is to really provide resources for people, and in bigger and bigger ways. What my fantasy, I guess, would be if it's some way I could, take people to an island or a location, secret location, and just, control their food,
Yeah,
take
exactly.
it for 6 weeks and just say, look, we're going to feed you. We're going to educate you. We might exercise you, and, just take away all the BS that people get stuck with. And,
Yeah, the only problem with that is like that would work fine. And that's kind of the way all those fat camps work. But you gotta teach these people how to negotiate the world that they really live in.
Right. So I mean, but that's, but you get them metabolically healthy, physiologically change them, and then educate them while they're doing it. And so,
yeah,
I think that people that really, and one of the problems with this is if we look around the low carb community, most people are over 40. Many of us are over 50. And the reason we're here is because we've experienced the negative, and then we experience the positive, and then our eyes are open. But most of the folks are in their 20s and 30s, and they still haven't really haven't developed the metabolic disease to the degree that it impacts their life. Some of them probably arguably you can find. Obviously, we see younger and younger patients now.
Oh my God, 29-year-olds coming in, horrible.
Yeah, even with cardiovascular disease, you see 29-year-olds having heart attacks, from metabolic disease.
You do.
What do you think the biggest? Myself and many others like me, and think that we've really missed the boat by focusing solely on dyslipidemia, or more specifically, high cholesterol. And we can talk about triglycerides and HDL ratios, because that's certainly a part of it. But are we missing the overall boat by ignoring some of these other metabolic markers?
Yeah, I mean, to be honest, I think you really hit the nail on the head there. I think one of the biggest roadblocks is that the damn focus on that one single LDL number. I mean, that is a huge roadblock. Maybe that would be my magical thing that I would love to get rid of. Is our singular focus on LDL, because if we can focus more on metabolic syndrome as a goal we should be fixing rather than LDL number, then we would be a much better place as far as our focus of how to direct our efforts on getting people healthier. That way, we wouldn't have to in the statins. Well, LDL statin, bam, cured. You've cured nothing. You've cured nothing. So I think the biggest biomarker I would follow would be like maybe waist circumference, or the waist to height ratio, and if we just did that, we would save so much money on these damn labs, and we would know so much more about our patients' health. I think I got that idea from Ted Naiman. I think it's absolutely spot on. We don't need to go through all the stuff that we do as far as lab testing, getting all sorts of biomarkers. The biomarkers are usually generally trend in the same direction, but as we can get the patient's physical body dimensions to change, then I know. If I see a patient who comes in between one visit and the next visit, and his weight didn't change, his waist circumference didn't change, I know, like, checking labs again 6 months later is just going to be a waste of money. it's going to be exactly the same. They're not going to change. Yeah.
Eric, I got to tell you, I mean, I've gotten so much pushback for sort of not ignoring the relevance of labs, but certainly saying that I think there's better things to check. I mean, not that you can't use them. And I think it's been frustrating for me, but can you imagine if I tell a physician, hey guys, your patients need to hit a waist to height ratio of under 50%. Let's just say we got to get everybody
Right.
in our, let's say 90% of the people in your practice need to have a waist to height ratio below 50%.
If that's, oh my God, if that was the marker that I'll get paid by, I mean, then that would be a much better thing than rather than these stupid, like, oh, by the way, what percentage of your patients are on statins? What percentage of your patients have A1Cs? If the only marker that they cared about was waist to height ratio, then we would be in a much better place.
But the problem with that is, as a physician, it's much harder to do that. It is way harder for me to get somebody to lose weight, to lean up, to lose their belly fat, than it is for me just to kind of reflexively hand them a prescription and be measured on that. I think that is one of the biggest travesties that we see in medicine, is we are measuring the wrong things. We put the emphasis on the wrong things, and we are doing basically disservice to our patient. We're not really getting after what really needs to be done. And I think that's across the board in every single specialty. And, like I said, if I could have a magic wand, that's maybe something I would do. I say, so let's start measuring the right stuff. And I
measure the right stuff. Right now we're measuring the wrong stuff.
Yeah. And I think, and the cost of that, you think about that, the lab industry is a multi-billion-dollar industry. And as you point out, the routine, well, in hospital, the daily labs, every day I'm going to check an H&H, every day I'm going to check an electrolyte panel. Right. How much money was generated and wasted doing those things? And how often did you act upon those labs that they made an actual difference?
Well, in the hospital, it's a different story. I usually can justify myself what I'm ordering in the hospital. But these routine labs, hey, every year, hey, doc, can I get my cholesterol checked again? You weigh exactly the same as you did last year. It's going to be the same, or you weigh worse. Maybe we'll check it again this year to make sure just to screen you, make sure you haven't lapsed into diabetes from your 20-pound weight gain since the last year. But a lot of the stuff is really not that important.
Do you find that a patient with high LDL cholesterol that has metabolic syndrome, maybe poor glucose regulation, systemic inflammation, is a different patient than a patient that has high LDL and doesn't have those other factors? Are they different patients?
Yeah, it could be very different. I mean, if you just have a high LDL and everything else, and then your triglyceride is like below 100, certainly, and your HDL is 50 and above, 60, 70, then that is a very different person. I could tell you what that person looks like. I can certainly tell you that person is going to physically look different than a person who has got a high LDL plus the high triglyceride plus the low HDL. That person, I just have a mental image of what that person looks like. They're very different. They're very different people, and so you can both have high LDLs. And so periodically, I do run particle testing on people. I don't do it on everybody because in general, I know the metabolic syndrome when I see it. But sometimes people do want an explanation for what their high LDL, and so I'll run a particle number on people.
One of the big, when I remember in medical school, when we first started learning about physical examination, one of the first basic thing they would tell you, just look at the person, get a general appreciation for what they look like. And, it would be patient appears to be older than stated age, younger than stated age, and a lot of people sort of say you can't tell anything by looking at a person. You could have a fit, athletic person and they are, there's no reason to think they're healthy. And I push back and said, I think, we can kind of look at the general fit athletic person in general. Now there's exceptions, obviously, but in general, they're going to be healthier than the person that is sedentary, significantly overweight, maybe
Right.
has some labored breathing, just sitting there.
Yeah.
It's just obvious to me, but I mean, the amount of pushback because they could say, hey, look, Bob Harper, the guy from The Biggest Loser, had a heart attack. Therefore, everybody that looks fit is no better than the people that are clearly
Yeah. Yeah.
obese. Do you agree with that sentiment, or do you think we can't tell anything by looking at someone?
Oh, you can tell a whole heck of a lot. And like I said, that's the reason why I walk around with the tape measure. Because that right there alone will help people determine what their state of health is. Yeah, there's going to be exceptions, and you'll have these people who are tolerating their obesity better than other people who are tolerating their obesity. But statistically speaking, how you look is going to dictate your long-term health outcomes.
Yeah, and I think it goes back to this waist to height ratio. I mean, it's far better
Yeah.
measurement than BMI. Obviously,
Right.
BMI is a kind of a blunt instrument. Screening is
Yeah.
cool. Obviously, a lot of people that,
Yeah.
it screens people, but then you have, people that are, fat on the outside, thin on the inside, or
Yeah.
thin on the
You
outside,
you
fat on the
you
inside.
can yeah, but the BMI, you don't have to touch anybody. You don't have to give them you don't have to wrap around their waist with the tape measure. So it's easier to collect logistically in medical offices, and that's why we like it. Yeah, again, people like yourself who are all who are heavily muscled. Yeah, you're gonna throw the BMI number. You're gonna skew the BMI numbers to be inaccurate. But in general, if you look at a person and most of that weight is sitting around their waistline, the bulging abdomen, yeah, then it's kind of reasonably close. But again, we'd be much better off if we were just kind of doing waist to height circumference.
Yeah, and just what things are pretty well correlated with waist to height ratio? Can we make some assumptions about insulin resistance and some of those other things based on that?
Yeah, I mean, all the metabolic, well, waist circumference is part of the guidelines for diagnosing metabolic syndrome. So that's what I usually like. I like to do. I like to count up that. So I think all the I can't off the top of my head I can't tell you, but I'm sure it's probably heart attacks, strokes, cancer risk certainly goes up, and then kind of usually non-deadly diseases like reflux and all that stuff all go up with waist circumference. And then longevity also really tracks very well with it. So if you're up there with the high waist to height ratio, you're going to be you could be knocking like 20 years off of your life, statistically speaking.
Should we? How important is ectopic fat, like say pancreatic, non-alcoholic fatty liver disease? Is that something I mean, obviously it's become at least endemic and perhaps epidemic. Do we undervalue that with regard to a lot of other diseases, and how do we fix it?
Yeah, well, yeah, we definitely undervalue it. A lot of people, it's found incidentally, like we order ultrasound all the time, and every day, you see the radiologist reading the hepatic steatosis. It just kind of gets buried into the body of like a radiology report. And you'll be lucky if somebody, if their doctor actually mentions that was seen, because most of the time, most people won't even, they're looking for gallstones or their gallbladder thickness or something along that line. And the fact that you have hepatic steatosis is sitting there, that is not going to even probably get mentioned to the patient because it's just so ubiquitous. But we see it all the time, like on CAT scans and liver ultrasounds and whatnot. So yeah, highly undervalued. And every time I see it, I bring it up to the patient. He's like, this means that you're probably working on, becoming diabetic, or you can end up with, cirrhosis down the line, I don't know how much of an impact that has as far as the patient in making lifestyle changes, but at least they've been told about it. Because most people have most of the time, sometimes I'll see a patient and I say, oh, it looks like you had an ultrasound 2 years ago. You had fatty liver disease back then. And the person's like, what? I don't know. Yeah. No, but nobody really mentions it.
Yeah, I'm sure you're familiar with Robert Sivas, and he's obviously gastric
Right.
a bariatric surgeon.
Absolutely.
He says that he sees fatty liver almost 100% of the time when he does a
100% of the
bypass,
time.
and he basically says that he puts them on a diet prior to bypass, and 100% of the time he gets rid of it within like a week, and it's basically a low carb, protein based diet, higher
Yeah,
protein
all of them. They
diet.
have they have these specialty diets. They'll put them on these, like, calorie restricted, high protein, no fat diets, just so they can do the bariatric surgery, so the liver doesn't get in the way of them actually performing the procedure. Otherwise, the liver would be so big that they couldn't actually they don't even have room to work. It's only a temporary measure for them, just to get them through the OR.
Yeah, I mean,
Crazy.
we basically have these human foie gras patients that are,
Yeah,
kind of
exactly.
stuffed with their giant livers and stuff.
Yep,
So that
exactly.
is, that's kind of interesting. But are you finding, are you finding that when you have a patient with, whatever, NASH or NFLA, non-alcoholic fatty liver disease, are you seeing success in reversing that? Is it something you measure? Is it something you care about?
Yeah, it's something that, I, longevity, longitudinally, I should be following more often. I'm not sure if I'm like rechecking it, sending people for scans to see. Mostly, I'm just kind of following their liver function testing. If the AST, ALT trends down, if I see that normalized, then I usually use that as a proxy. And I usually don't get an anatomic assessment.
Yeah, I mean, you have something called a fatty liver index. I mean, it's BMI, it's waist circumference, GGT, and triglycerides, and so that's
Yeah,
kind of it's got like an 85% correlation with fatty
yeah.
liver. I don't know if you ever utilize that as a tool.
No, I don't. But yeah, maybe, perhaps I should be.
Yeah, maybe.
Yeah.
Hey, I've got one last question, and this is a little bit
Sure.
controversial. So,
Uh-huh.
obviously, we're in the world of this COVID-19 coronavirus, and there's a
Yeah.
lot of passion on both sides about, how we've responded. Should we have locked the whole world down? Should everybody be
Right.
wearing masks? Should we not? But one of the things that, and I don't know what your thoughts are on this. I mean, I think we have largely missed a opportunity to talk about host factors, to talk about vulnerable populations, particularly
Right.
those at risk with either obesity, hyperglycemia, metabolic syndrome. We clearly are seeing tremendously increased morbidity and mortality rates in those populations. And
Right.
I just find that we have not addressed it at all, except a few, there's a few people out like John the Baptist out there screaming in the wilderness about it. But it seems like the whole response from not only U.S. government, but all governments has been really to just sort of not even address that issue in any meaningful way. Do you share
Yeah.
that frustration at all? Do you think we missed the ball on this?
Yeah, I think we certainly do. I mean, certainly there are people who have been screaming about it. I mean, Sarah Hallberg has been calling about, for metabolic health, and and try to get that under control, because those are the people with the um, and those are the people who are dying. Certainly, or being hospitalized, and those certainly are the people that I've been seeing in the hospital. I'm not seeing, fit, healthy people get hospitalized with COVID. It's either, elderly or risk factors like obesity and diabetes. And unfortunately, a lot of people are taking this opportunity of this lockdown, and this to coming back saying, "Yeah, I've been at home. I've not been eating right. I'm just around the kitchen. I'm just eating whatever. I'm eating Chef Boyardee, uh, or I just, my Nabisco cookies are there, and mac and cheese." And so a lot of people have been doing the exact 100% opposite to improve their metabolic health, to make their chances of them surviving a case of COVID any better. So unfortunately, some people are doing better under these circumstances. A lot of people say, "Well, I can't go to my favorite restaurant anymore, and I don't want to buy uh, takeout." So I've been, I lost some weight because of that. So it goes both way, but more people are unfortunately eating poorly during the lockdown period that I've been seeing. Well, now they're coming back to the office finally. That when they're coming back, a lot of them are coming back heavier. And unfortunately, And I always tell them, I say, listen, best thing you can do for yourself right now is make sure that you're ready for that COVID. If you so happen to get it, it will vastly improve your, well, I can't say this for sure actually, but it's my, this is, it just makes sense that if the people who are getting sick are obese and diabetic, it's best to tend to that before you get sick.
Yeah, because there will, obviously, as throughout history, there will always be another illness that's going to come through, another infectious disease.
Right.
So that's clear. And it's interesting you say that, you're generally seeing what is being reported, in general is that, most of the people are, compromised some way. But it seems like anytime there's a young person that gets it, that is just plastered all over the media to sort of kind of support some of these other measures that are out there. And I think it's overemphasized that, oh my gosh, there's a young person that died. And we see that, certainly with influenza, young people die from that. With any disease out there, there's a small cohort of younger, healthier people that get that. And we don't seem to make the big deal about it as we do with this particular situation. I know there's reasons for that. And Chef Boyardee, I remember the ravioli. I would eat those giant. They came in the giant can. That would be. I would eat that. I remember eating those all the time. I think I like that better than the beefaroni version.
Yeah, I mean, it's on the people went into lockdown and they stored up. They got their rice, they got their spaghetti, they got their mac and cheese, they got their Chef Boyardee. I've seen these news articles about how these packaged food companies are doing like business like they've never done before, like in the last 50 years. And it's a shame because, you got all this time, you can cook real food. You don't have, you got time and, just cook real food, don't have to resort to the worst of the worst.
Yeah. The other frustration was alcohol sales were up at all-time highs as well. People were stocking up on alcohol and, that was considered an essential, the alcohol stores were considered an essential, facility, I guess, because we don't want alcoholics going into DTs, apparently.
Well, Sean, this is actually was a real problem, at least because we had shut down the liquor stores like transiently in Pennsylvania. And in that really brief period of time, I was seeing a lot of people coming with alcohol withdrawal seizures into the hospital. So that was a real risk to these people because these people were suddenly cut off, and then that came in, and then they declared it, and then they can go back to drinking. But there was a brief period of time where we saw like a couple of days where we saw an uptick in the number of alcohol withdrawal admissions. Yeah,
that's a sad commentary that we have that our population is so bad that we can't shut down the liquor stores out. A bunch of people.
Unfortunately, alcohol withdrawal is life-threatening. It's life-threatening.
Yeah. So anyway, we've got the head shops, the liquor stores open, and the gyms closed, and it's kind of just interesting. Anyway, Eric, thank you so much. We've come to an hour. I don't want to take any more of your time. Appreciate you coming on a Sunday. I salute you for being another physician that's willing to kind of go against the grain, so to speak, and and do what you're doing. I think the more that we do this, the more folks that are empowered, particularly in the medical community, and I think eventually we'll hit that tipping point. And whether you do it within the side of the system, which I think is a harder route to go, because you definitely got a lot of obstacles in your way, and I applaud you for trying to do that versus people that are kind of stepping outside the system and doing it that way. Either way, it's just we need more people to do that. So thank you very much, Eric. Where can people find you, follow you, learn more about you? Maybe if there's patients interested in seeing you. Oh, the one question I want to ask: are you seeing any patients virtually? I know with coronavirus, lots of people have adopted that. Have you been able to do that, or is that something you do on a regular basis?
Yeah, we hopped onto the telemedicine bandwagon back in, I don't know, in April or something like that. So we started firing that up. We were doing an awful lot of them. Now we're seeing more patients. Yeah, but we're seeing people virtually. Sean, I'd like to thank you because I have been seeing some MeetRx patients show up at my doorstep. So people are definitely showing up. So I want to give you a thanks for all the recommendations and some additional business thrown my way.
Sure, and we'd love to support you. And like I said, conversely, if you have any patients you think would be appropriate for what we do, we certainly appreciate the pointing them in our direction as well.
No,
I
I've
think
been
it goes both ways.
getting a lot of carnivores, and I won't say a lot, but I've been getting my share of carnivores. People are kind of amazed that that when they say when they admit to their doctor they're carnivore, that the doctor doesn't look at them or have no idea what the hell they're talking about, or is actually supportive, or it's actually I'm really very interested in them. So I have a lot of people who just look at me in amazement with kind of their jaw slack, like, "Oh my God, here's a doctor who doesn't like, who's not going to lecture me about being a carnivore." They're kind of amazed that somebody like me exists.
Yeah, thanks, Eric. And there's a few out there, and they're
Yeah,
growing. We've got,
yeah,
like, I don't know if you know, we have a physicians portal on this site. We have about 150 physicians that are, in there, and so they can discuss
yeah,
different things. And
yeah,
we're like I said, I'll probably reach out to you in the near future to talk about some more stuff regarding
yeah.
that. But anyway, thanks again, Eric.
You're
Enjoy
welcome.
your Sunday. Keep doing the good work, and we
Right.
certainly appreciate your time here. Thanks again, guys. All right, everybody. Y'all take care. Have a good weekend, and I'll see some of you guys tomorrow. All right. Bye, everybody.
Bye bye.